Hello, good afternoon everyone. I am Dr. Siddharth Saxena. I'll be presenting about retrograde intrarenal surgery, or RIRS as it is commonly called. Now, RIRS is basically a surgery without incision, and the surgery involves going within the renal pelvic calyceal system using our special instruments and scopes, which are of various sizes that are available to us. The advantage is that there is easy accessibility of the proximal ureter as well as the renal collecting system, which has a great advantage because the stones in all of the calyces can be assessed through the same access tract rather than having different punctures in the PCNL. Now, coming to the broad aspect, they can be diagnostic and therapeutic indications to do a retrograde intrarenal surgery. Coming to the diagnostic indications, we have for evaluation of patients with hematuria, patients who are suspected with upper tract urothelial carcinoma or malignancy, in which patients there are radiographic filling defects or obstruction, and where papillary necrosis, especially in diabetic patients, are suspected with hydronephrosis evident on imaging. Now, this is a briefly image that shows one of our patients. He presented to us with hematuria, and however, the ultrasound was not suggestive of any mass lesion, or there was no stone also visible in the non-contrast CT that was done. However, when we did a scopy, we found, you can see that these are the mass lesions that are present within his proximal ureter and pelvic calyceal system. This is again a patient. He was actually planned for a renal transplant. This is actually a CKD5D patient. He was planned for renal transplant. He presented to us with hematuria, and you can see over here, this is the ureteric mass lesion in the proximal ureter in this patient that was present over here. Coming to the therapeutic indications for retrograde intrarenal surgery, which are the most common and most useful in these patients, is for the stones with less than 1.5 centimeter in size, stones in which we want to assist with ESWL in radiolucent stones, because in them PCNL punctures would not be very well appreciated. Patients in whom there are concomitant renal as well as ureteral stones, so as to have clearance in the same settings. Patients in which there is calyceal diverticular stones, where there is nephrocalcinosis, some anatomic obstruction is suspected, or in supravesical diversion patients. Now, broadly speaking, one of the prominent and probably the only main contraindication to our RIRS surgery is infected setting. We do not want to do such a case in an infected renal system, because there is a chance of migrating of the bacteria through the pylolymphatic and pylovenous system, because there is a positive pressure that we do during our scopies, which may result in sepsis in these patients. So the only contraindication that we actually have is an active infection or active UTI for these patients. This is the scope and camera that we typically use, which is having these various components of irrigation and suction and a light connection for the same. Now, broadly, preoperative assessment that we do of these patients is a CT urography. Then we take the informed consent of the patient and counsel him regarding the available procedures, including ESWL, PCNL, RIRS, and other modalities. A preoperative urine culture we get to rule out any active infections in these patients with giving of prophylactic antibiotics. We do prefer it under general anesthesia. However, the same can be done under spinal anesthesia and to some extent under local sedation also. We do it in a dorsal lithotomy position and after padding all the pressure points. Now, the advantage of RIRS is, broadly, if you can appreciate, this is the flexible tip of the flexible scope, which can move almost to 270 degrees and 120 degrees over here. So it can actually visualize the stone, but here lies the disadvantage of RIRS also, that while flexing the scope till 270 degree, I can visualize the stone, but I cannot fire the laser to break the stone, otherwise it will damage the scope. So here, amongst the steps of RIRS, the relocation comes in. When we are able to see the stones, we try to keep the scope in a position where the laser can be fired rather than firing the laser on the scope itself. Now this is how it looks inside when we are doing the surgery. Here we are already in the renal system where we can visualize the stone in the upper part, in the upper calyces that we can visualize. We break the stone using a holmium laser that is shown over here, and individual fragments of the stones are then retrieved through forceps. This is to demonstrate that not all patients may even require the laser setting. This is one patient that we did recently who had very small 5-6 mm stones only, and he wanted clearance in the same setting. So what we did was we just grasped the stones using our scope and the basket which is made of nitinol, and just by basketing we were able to retrieve all the stones in one setting. So we were able to provide him incisionless, painless procedure without any complication for multiple small stones in this setting also. Now in patients where there is a larger stone that may not be amenable to a single retrieval, we use a holmium laser to make multiple fragmentations of this stone, and then individual fragments can be brought out. Here we are using a holmium laser with a 200 micron fiber, and we are demonstrating how we are fragmenting the stones into smaller fragments. As you can see, this one fragment has just gotten loose over here, and subsequently each of these fragments are dusted into small parts and then retrieved. Now, the versatility of these scopes is in the directions that we can use. It has a counterintuitive as well as intuitive direction by which we can assess each and every system of the kidney. So if we are it's like driving a car for us. So we know when we have to turn left and right, it determines each and every calyceal systems of the kidney. Now we have various lasers that we use for this. We have thulium laser, we have holmium laser, but holmium here is the most commonly one which we use, and it basically breaks down the stones using a photothermal mechanism with the Moses effect. And the ability of the holmium laser is very good to fragment all of these stones. There can be various settings that we can use. One is called as popcorning effect, in which the stones basically break in the form of a popcorn that we can see in, we have mostly seen in cinema halls, how the popcorn goes off when it starts off. The other is dusting effect, where the stones are basically broken down into small dusts. Now the benefit of these is that holmium provides smaller fragments of the stones. Therefore, it is able to give much better surgical outcome. Also, there is minimal chance of retropulsion. So the stone chance that it moves into some other system, some other callus or some other part in the kidney is very minimal in the holmium laser. And the best part is that it can be used in anticoagulated patients as well, because a lot of patients are already on blood thinners today. And for these patients to skip the blood thinners is a cardiac risk. So for these patients to avoid the complication with PCNL, to avoid stopping the blood thinners, we generally advise for RIRS. Now, one of the most essential part of RIRS is that clear vision should be available throughout the time, because when we start breaking the stone, there is something called as a snowstorm effect that comes into play. If you can see here, while we are breaking the stone, we can see a haze of stone fragments that is coming into the RIRS scope continuously. This is called as a snowstorm effect. It is basically looks like a snowstorm, and during this time it's very essential for the assistant who is assisting us to provide a positive pressure in the kidney to give a better vision available to us. This is an image of the same machine that we typically use. Now, coming to the recent EAU guidelines of 2025, this is the European Association of Urology guidelines that they typically give. So the current recommendation, as we can see, for stones of less than 10 mm in size, they have given as a first recommendation with the shockwave lithotripsy or RIRS, which was previously not there. So now the current recommendation says RIRS for even less than 10 mm stones. For 10 to 20 mm stones, shockwave lithotripsy with RIRS is the only recommended option. For more than 20 mm stones, RIRS is still considered as a second option because of multiple setting may be required for these patients, because in a single setting, the entire stone part may not be able to be cleared, however. Now, in certain patients where there is a lower pole stone of size 10 to 20 mm, in which ESWL or shockwave lithotripsy cannot be done, for those patients, there is still a recommendation of RIRS. Now, even though it has so many benefits, there are, however, some complications associated with RIRS, which may include a failure to assess. So if we are unable to go into the ureter or kidney because there may be an associated ureteric stricture, some narrowing, some mass, which may not allow our scope to reach into the desired callus, there can be we may have to abandon the procedure in midway. Then stone migration can be there into the ureteral wall, which can be mostly because of the false firing of the laser fiber. So if we are firing the laser while pushing the stone against the ureter, instead of fragmenting it, it may migrate the stone into the wall of ureter rather than breaking it. And there can be failure to fragment the stones, which is usually encountered generally in very hard calcium oxalate stones, in which the laser is unable to fragment these stones despite us reaching the stone adequately. There can be associated mucosal trauma if at the pelviureteric junction, especially if we are not correctly using our scopes. And ureteral perforation is one of the rarest complications of this procedure. There can be minor complaints post-operatively, which may include hematuria, some renal colic secondary to a small residual fragment, stone, or a blood clot, pyelonephritis, or a urinoma. So the most important thing that we do post-operatively is actually put in a stent. That is the peace of mind that we have. So as long as the stent is there, none of these minor complaints will be there in the patient. We follow up these patients with after 2 weeks with a scheduled visit, and we get a X-ray KUB to determine that there is no residual stone or fragments present and the position of stent is in place. Subsequently, usually at 4 weeks, we remove the stent in these place. Concluding, RIRS is now an integral part of the armamentarium of us urologists, and it is a valuable tool for both in the treatment of renal stones which are refractory to ESWL, as well as for upper tract pathology, including upper tract urothelial carcinomas. And nowadays, with the refinement of techniques and the newer scopes that we have, the complications like stricture, perforation, extravasation, they have been significantly minimized. And it is a very effective and safe therapy, especially for cardiac patients who are on anticoagulation therapy, who require stone removal in them. And it does not require any stoppage of the anticoagulation modality. Thank you.